The lesion of white sponge nevus usually appears at birth or in early childhood, but sometimes the condition develops during adolescence. Symmetrical, thickened, white corrugated or velvety, diffuse plaques affect the buccal mucosa bilaterally in most instances. Other common intraoral sites of involvement include the ventral tongue, labial mucosa, soft palate, alveolar mucosa, and floor of the mouth, although the extent of involvement can vary from patient to patient. Extraoral mucosal sites such as the nasal, esophageal, laryngeal, and anogenital mucosa appear to be less commonly affected. Patients are usually asymptomatic. Treatment and prognosis. Because this is a benign condition, no treatment is necessary. The prognosis is good. And there's a picture of it. And this is all in white sponge nevus. Next question, periodontitis and doxycycline. Doxycycline, they inhibit the collagenase in clavicular fluid. Periodontitis and doxycycline. Doxycycline inhibits the collagenase in the clavicular fluid. It is effective against a broad spectrum of microorganisms used systemically and applied locally, subgingivally. Doxycycline has the same spectrum of activity as minocycline and may be equally as effective. Because doxycycline can be given orally once daily, the patients may be more compliant because it's just a pill that can take once a day, even though doxycycline has the same spectrum of activity as minocycline. Compliance is also favored because its absorption from the gastrointestinal tract is only slightly altered by calcium, metal ions, or antacids, as is absorption of other tetracyclines. The mechanism of action is by suppression of the activity of collagenase, particularly that produced by polymorphonuclear leukocytes. Next question. A patient has hip replacement a year ago. What kind of treatment can you render? Answer: antibiotic prophylaxis. Given the potential adverse outcomes and costs of treating an infected joint replacement, antibiotic prophylaxis given the potential adverse outcomes and costs of treating an infected joint replacement, the American Association of Orthopedic Surgeons recommends that clinicians consider antibiotic prophylaxis for the total joint replacement patients prior to any invasive procedure that may cause bacteremia. Premedication to knee and hip replacement is sometimes advised. They are more likely to be premedicated if the hip replacement was recent, meaning less than 2 years. And the AHA antibiotic regimens are often used. The American Heart Association. However, if in doubt, send for medical consult. Next question. When can you give a patient with a heart condition? What can you give a patient with a heart condition? There are drug considerations for patients with heart conditions. So, for patients taking digitalis, avoid epinephrine. Again, for patients taking digitalis for cardiac heart failure, avoid epinephrine. If considered essential, use continuously a maximum of 0.036 milligrams of epinephrine or 0.20 milligrams of levonorepinephrine. Avoid gag reflex. Avoid erythromycin and clarithromycin, which may increase the absorption of digitalis and lead to toxicity. So, important. If taking digitalis, avoid the use of erythromycin and clarithromycin because this may increase the absorption of digitalis and lead to toxicity. For patients with let me check what this is. For patients with NYHA, which is New York Heart Association Class 3 and 4 congestive heart failure, avoid the use of vasoconstrictors. Now, what is New York Heart Association Class 3 and 4? New York Heart Association Class 3 and 4, 3 means that there is a marked limitation in activity due to symptoms even during less than ordinary activity, like walking short distances. And 4 is severe limitation, experiences symptoms even while at rest, mostly bedbound patients. And the New York Heart Association classification provides a simple way to classify the extent of heart failure. If it classifies patients in one of 4 categories based on their limitations during physical activity. The limitations and symptoms are in regards to normal breathing and varying degrees in shortness of breath and or angina pectoralis. So for patients with class 3 and class 4 congestive heart failure, avoid use of vasoconstrictors. Class 3 and class 4 are, class 4 is a severe limitation, which is a patient that experiences symptoms even while resting, mostly bedbound patients, and class 3 is marked limitation in activity due to symptoms, even during less than ordinary activity, e.g. walking short distances, and they're only comfortable when they're at rest. So in these patients, with this kind of congestive heart failure, avoid the use of vasoconstrictors. If use is considered essential, discuss with a physician. Now, avoid epinephrine impregnated retraction cord. Use retraction cord with aluminum potassium sulfate instead. So, aluminum potassium sulfate is the other substance that can be used instead of epinephrine for a retraction cord. So don't use epinephrine impregnated retraction cord when you are treating a patient with a heart condition. Schedule short, stress-free appointments. Use semi-supine or upright chair position. Watch the orthostatic hypotension. Make position or chair changes slowly and assist patient into and out of chair. Avoid the use of non-steroidal anti-inflammatory drugs. Watch for signs of digitalis toxicity like tachycardia, hypersalivation, visual disturbances, etc. Nitrous oxide oxygen sedation may be used with a minimum of 30% oxygen. Next, contradiction for implant myocardial infarct. Smoking. Oh, contradiction for implant myocardial infarction, bone loss, or smoking, or adolescent. The implant team should avoid potential implant patients of the detrimental effects that smoking has on their oral systemic health. Complications must be discussed and highlighted in the informed consent. Patients should be encouraged to start a smoking cessation program before implant treatment. Smoking is not an absolute contraindication, however, the risk of possible morbidity on the respective procedure must be evaluated. Note: relative condition contraindications are people who have uncontrolled diabetes and smokers. Absolute contraindications, mental or psychological disorders, people under age of 16, people who are too critical, or one can't please. Next question. How long do you splint with avulsion? 7 to 10 days. If there's a bony fracture, 2 to 8 weeks. I'm not sure where they got the 2 to 8 weeks. Bony fracture should be 3 to 4 weeks in children. Okay, so the splinting of avulsed teeth. Composite resin and nylon fiber, 0.6 millimeter of diameter, such as a fishing line, 20 kilograms breaking strain, or orthodontic brackets with an arch wire. Orthodontic appliances are particularly useful as the time taken to apply the brackets is half that to set composite resin. Splints should be flexible to allow normal physiological movement of the tooth. This helps to reduce the development of ankylosis. However, if there is a bone or root fracture present, then a rigid splint must be used so that there is no movement of the teeth and bony segments. Again, splints should be flexible to allow normal physiological movement of the tooth. This helps to reduce the development of ankylosis. However, if there is a bone or root fracture present, the rigid splint must be used so that there is no movement of the teeth and bony segments. Splints should generally stay in place for 7 to 10 days if there are no complication factors such as alveolar or root fractures. The occlusion may need to be relieved when the degree of overbite or luxation is such that the tooth receives unwanted masticatory force. This can be achieved by minimal removal of enamel or construction of an upper removable appliance or placement of composite resin on the molars to open the bite. Some physiological movement is necessary. Close reduction with plastic tooth with fingers. Dental alveolar fractures. With luxation of teeth, the alveolar plate can be fractured or deformed. Again, with luxation of teeth, the alveolar plate can be fractured or deformed. Use firm finger pressure on the buccal and lingual plates to reposition. It should be remembered that alveolar fractures can occur without significant dental involvement. These alveolar fractures should be splinted for 3 to 4 weeks in children, 6 to 8 weeks in adults. So, luxated or avulsed teeth usually result in alveolar bone fracture and or displacement. Firm pressure is needed to reline bony fragments. Splinting may be required for 3 to 4 weeks in children. Again, luxated or avulsed teeth usually result in alveolar bone fracture and or displacement. Firm pressure is needed to realign bony fragments. Splinting may be required for 3 to 4 weeks. Dental splinting times for root and alveolar fractures usually used to be 2 to 4 months, but recent studies show splinting for 3 weeks is sufficient. Next question. Why is core better than another? Why is core better than another? Answer, it lets out fibers.